This is Dr. Wayne Inglis from Vanderbilt University Medical Center. Before I speak, I'd like to first thank Dr. Chen and Dr. Flock and the SAGES Program Committee for the opportunity to speak here today. It's an honor to start off the lectures here with the Building a Comprehensive Weight Loss Center session, discussing the new MBSAQIP standard with you. First, I want to go over my disclosure slide here. Really, the only relevant thing will be that I am co-chair of the Standards and Verification Subcommittee for the Committee for Metabolic and Bariatric Surgery. As we know, there were two previous versions of the MBSAQIP standard. First one effective May 2014, and the next one coming in October of 2016. The current 2019 standards are effective as of October 2019, and all MBSAQIP accredited programs should be well on their way in meeting the requirements for accreditation. Lots of people helped out in developing this third version of the standard. There's the Standards Verification Committee members, and the Ambulatory Surgery Center Surgeon Task Force, as well as the Obesity Medicine Medical Weight Loss Task Force. I'm not going to go into all of the bullet points here, but this essentially shows you that our work is never done on the Standards and Verification Committee. As you can see, immediately after the standards are effective, from 2019, we're already working on version number 4 of the standards, and this goes on for the next 3 years until we come out with the next version according to the necessary changes that come up for policy changes, and some of the standards may be sunsetted, some are newly developed according to new data that arises. There's been an alignment for the American College of Surgeons quality programs here. There are multiple quality programs such as MBSAQIP, the trauma for geriatric surgery, etc. There are multiple quality programs. But for MBSAQIP, essentially it was all rebucketed, and a realignment took place not to change the content of the standards, but basically to unify the content for all of the quality programs across the board and make the formatting and platforming uniform, so it makes it easier to discuss one quality program to the next. The numbering and the standards of the chapters here may have changed a little bit. Some have been removed, some have been rolled into and split up, and we'll discuss that here. Here's some of the highlights for standard 3, for standard version 3. There's been some massive clarification edits and rewrites to improve the document readability and comprehension. These include some edits to the Metabolic and Bariatric Surgery Committee and the Medical Advisor for Adolescent Program. There's been consistent language changes to align with the MBSAQIP registry, as well as patient-first language throughout the document. Every standard has been edited in one way or another, even those without any significant substantive changes. Several standards have been split or combined, and again, now everything is aligned with the new variable definitions used in the MBSAQIP registry. There's been some increased direction and clarity on what's expected with the quality improvement standards. The adolescent center standards have been edited, and there was an addition of an obesity medicine qualification standard. For version 2 of the standard, you can see there were 4 designation levels here: comprehensive center with adolescent qualifications, low acuity center, and adolescent center. Now there are 2 additional designation levels with the addition of the obesity medicine qualification option. Basically, this standard necessitates an obesity medicine director. The obesity medicine services must provide comprehensive medical evaluations and assessment, testing, counseling, and the documentation of obesity medicine. Data collection is essential. However, MBSAQIP does not have the capability of providing the registry for the obesity medicine option. Standard 1.1 for administrative commitment. The new standard, basically we need a letter from the facility CEO documenting the commitment for multidisciplinary care and supporting the bariatric surgery program. There's been volume requirements that have been decreased for the adolescent centers. This was decreased from 25 stapling cases per year to 15. This was based on the published teen lab data. And now adolescent surgeons only need the verified co-surgeon if they're performing less than 15 procedures per year. For low acuity centers, the patient selection criteria remain the same. However, this now also includes the gastric band procedure. Previously, bands were excluded from the low acuity restrictions. In version 1 of the standards, there was no separate ambulatory surgery center standard. They were simply designated as a comprehensive center. In version 2, what happened was there was outcry from insurance companies and patients being a little confused as to whether ambulatory surgery centers could actually perform at the same capacity as a level 1 trauma center. Therefore, a separate ambulatory surgery center standard was created. And then update in version 3 include that all cases must meet the patient selection criteria, and they are now approved to perform revision cases, but this only applies to gastric banding to sleeve conversions only. For a center to be allowed to do this, they must be performing at least 50 stapling procedures per year. The clinical reviewer position can be outsourced. This is acceptable, but must be fully compliant with the standards. Regarding standard 3.2, the facilities, equipment, and furniture, labeling is now optional, it's not required. You must have a weight-rated or supported toilet, and there's some clarification on protocols for patients who exceed the weight limits. Regarding surgeon verification, there's a universal annual volume count from any accredited center. You can become a verified surgeon if you're participating at 2 or more accredited centers. The portability language has been removed, and there's been better definition of the quality meetings as to what qualifies and clarification of the CME credit requirement. Standard 2.9 for the designated area facility within the hospital for consistent nursing staffing. This has basically been split into standard 3.3 and 4.4. Regarding the staff training, the order was changed and the items were clarified. For the multidisciplinary team, we added that a consistent operating room team or staff should be available and well documented. Anesthesia protocols have been clarified. This was a very common, frequently asked question for MBSAQIP, so we're trying to make it as easy as possible for you to develop this particular standard. Critical care services, now it's been clarified so that you provide proof of services on site and documentations of credentials. For the adolescent centers, standard 9 no longer exists. It is now rolled into standard 4.13 to 4.15. Regarding the pediatric medical advisor, this individual is required to attend the annual comprehensive review meeting and all meetings where pediatric patients are discussed. Again, the reduction in the adolescent volume requirements here and edit regarding the co-surgeon requirement. For the ambulatory surgery centers, standard 8 no longer exists. However, you must document inpatient admitting privileges and a risk assessment protocol for patient selection. Regarding data entry, there's a new protocol for monitoring patients going to the emergency department and being readmitted outside of the facility. This was only required for ambulatory surgery centers previously, but is now required for all designation levels. Regarding 30-day and long-term follow-up, there has been some update to match the MBSAQIP registry definitions. Adverse event monitoring was also simplified and clarified. The mortality review has been extended from 30 days to 90 days. Quality improvement changes were made to address frequently asked questions regarding high outlier status and whether or not we should document the last quality improvement project that is still underway. We need to at least provide a timeline for completion at the site inspection. Templates were also added to make it easier for centers to participate in quality improvement projects. Regarding the annual compliance report, this has always been a requirement, but somehow it's been buried and it would not rigorously controlled, I guess. But now it's its own standard, and the MBSAQI staff are going to be looking at this in greater detail for the future. Regarding support groups, previously the requirement was 4 support groups per year. Now it is 6, and there's some clarification on a licensed healthcare provider being present at the support groups. This is the highlights and the updates for the new 2019 MBSAQIP standards. I would encourage you to go to the MBSAQIP website and go to the past webinar recording to the May 30th, 2019 webinar. This particular webinar discussed the changes that were being made to the 2019 standard. By the way, over 300 participants per month are engaged on the Ask MBSAQIP call. That is the conclusion of my talk. I would like to thank you for listening, and I encourage you to go on to other sessions to learn more about what SAGES has to offer virtually. Thank you again.